Good evening, friends. Today we're going to see Hepato-Biliary Pancreatic chapter and also from Transplant. So this is a continuation of the recall series which is going on from team RRM and DocTutorials. Every year we get a lot of questions from biliary system, pancreatic system and liver also. So the points we have to remember here are, let us discuss the important questions now. Which of the following type of choledochal cyst can be mistaken for accessory gallbladder? So this is a very important question, which is mistaken for accessory gallbladder according to Todani classification. This is Todani classification, also called as Alonso classification. Tell me the answer for this. So answer for this question is Todani or Alonso. What is the answer for this question? Yes, welcome. Welcome all. Yes, what's the answer for this question? So the answer here is type 2 choledochal cyst. Can you see? It is looking like a diverticulum. So type 2 is a diverticulum from the bile duct. So diverticulum looks like an accessory gallbladder. That is type 2. Type 2 looks like an accessory gallbladder. The most common type is fusiform dilatation as shown here. So type 3 is choledocal. That is type 3 is choledocal. It's a diverticulum near the ampulla. This is the least common type. Choledocal is the least common type. 4 is divided into 4A, which involves all the ducts. A for all, including extrahepatic, intrahepatic. B is extrahepatic only. Okay, B is only extrahepatic. 5 is Carolis. So can you tell me in which of these 5 types there will be anomalous pancreatic bile duct junction? Is always seen in 2 of these types. What are the 2 types where anomalous pancreatic bile duct junction is seen? Can you tell me the answer for this? That's very good. Most of you are correct. Where will you get anomalous pancreatic bile duct junction? Type 1 and type 4. In these 2 cases, we have anomalous pancreatic bile duct junction always seen. So this is nothing but because of the anomalous junction, the pancreatic juice reflects into the bile duct and causes damage of the bile duct. So this is from Sabiston, page number 1504. So don't forget, type 2 appear as a saccular diverticulum may be mistaken for accessory gallbladder. See, 70 to 80% of the questions what you get in NEET SS will be direct lines from Sabiston. So this is a classical question. So very good, Dr. and Chandan, all of you are correct. Type 1 and 4 has anomalous pancreatic bile duct junction. Type 3 cyst appear as a cystic dilatation of the intramural CBD. So and are also known as choledocal. It's an intramural CBD diverticulum. So the second question, you can see malignant patient, 88 years old with sepsis, with acute cholecystitis, with end-stage renal disease and cardiac morbidity was also there. So what is the management for this case? So this is the case of Tokyo guidelines. Severe cholecystitis, severe acute cholecystitis, where there is classically organ failure seen. When there is an organ failure, which is measured by serum creatinine, more than 2, fall in PaO2, oxygen saturation decreasing, patient is in shock, patient has low platelet count. So all this will be considered under severe acute cholecystitis. In a severe acute cholecystitis, the very classical answer is tube cholecystostomy. So please understand this is a classical question for a very morbid patient who is having severe acute cholecystitis. Call the radiologist for a tube cholecystostomy like this. So this is a tube cholecystostomy. So after doing tube cholecystostomy, after 6 weeks, so wait for 6 weeks. After 6 weeks, you can reassess the patient. Reassess the patient. If the patient is fit for surgery, go for cholecystectomy. Go for cholecystectomy. If the patient is unfit for surgery, you can remove the tube and we can wait. That's all. Remove the tube and leave it. That's all. Leave it. And leave or follow up the patient. This is a point from Sabiston. Don't forget, tube cholecystostomy is done. Wait for 6 weeks and reassess. The patient is fit after 6 weeks, you can go for a cholecystectomy by lap or open method. If patient is unfit, no need to do cholecystectomy because the patient has resolved the symptoms now. You can just put remove the T-tube and send the patient, remove the tube, the tube which we kept, no, the pigtail catheter, remove the tube, pigtail catheter, and you can send the patient home. That is another point. So some patients with acute cholecystitis have a probability high operative risk. For these patients, a percutaneously placed cholecystostomy tube should be considered. It is performed under ultrasound guidance using local anesthesia. Cholecystostomy can act as a temporary measure. In patients with a cholecystostomy tube, in future, when fluoroscopy shows a patent cystic duct, cholecystostomy tube can be removed and decision for cholecystectomy determined by the patient's ability to tolerate surgical intervention. So percutaneous drainage resolves the symptoms, allowing a delayed cholecystectomy even after 3 to 6 months after medical optimization. These are all direct paragraphs from Sabiston. So you read each and every line of Sabiston expecting that can come as an MCQ. Definitely you'll get those questions as exam questions, okay? So similarly, there is another question. Patient with a fever, hypotension, jaundice. MRCP showed impacted stone in the CBD. So there is a impacted stone in the CBD. So this is a stone in the CBD. Patient has pain, jaundice, fever, plus shock. Let us assume there is mental changes also. So this is a case of Reynolds pentad. Don't forget, this is a case of Reynolds pentad is present. The patient is in severe cholangitis due to Reynolds pentad. MRCP shows there is a stone in the CBD and the gallbladder might have some stones. So what should be the next line of management? So antibiotics with the biliary drainage within 24 hours, urgent choledochal lithotomy with the cholecystectomy, conservative with antibiotics, conservative with the ERCP after 4 days. So please remember, ERCP is not delayed. Start with antibiotics and plan for biliary drainage using ERCP, sphincterotomy, and biliary drainage. That is a gold standard treatment. So ERCP plus sphincterotomy plus biliary drainage. If this procedure fails, if ERCP sphincterotomy fails, then we have to go for a percutaneous transhepatic biliary drainage of the bile. If that is also fails, then only the last option is CBD exploration. Okay, that is the last option. Only when everything else fails, we will go for that last option. Okay, don't forget this. That you should not forget this CBD exploration as a last option. ERCP, sphincterotomy, and biliary drainage. If it fails, go for PTBD. If it fails, go for CBD exploration. So please don't forget adequate hydration. IV antibiotics should be started immediately. Many patients will improve with the medical therapy. However, these patients require emergency decompression of the biliary tree. So endoscopy or percutaneous drainage achieves this goal. If endoscopy and percutaneous means are unavailable or unsuccessful, surgical drainage consists of CBD exploration with the placement of T-tube. So given the unstable nature of the patient, definitive surgical treatment of the cause is deferred until the patient is stabilized, cholangitis is treated, and the diagnosis is confirmed. Okay, don't forget. So the stepwise, you should not forget. First ERCP, then PTBD, then you should go for CBD exploration. It can be open or lap. It depends upon the surgeon's skill. Okay, so we have to open the bile duct and remove the stone and keep a T-tube. That is a very important protocol for cholangitis cases. So that is a question from Bailey and Love. So this is from Bailey and Love, 28th edition Bailey and Love. Modified 2018 Tokyo guidelines is used for acute cholecystitis. So this is a new update in Bailey and Love. I hope most of you would have read this point. Tokyo guidelines for acute cholecystitis is fully updated, and the severe acute cholecystitis, as per Sabiston, the treatment of choice is percutaneous drainage. But Bailey and Love has updated a very important point. If there are no negative predictive factors, and you have a good institutional setup, good institution with a good laparoscopic setup, in these cases, we can even go for yearly cholecystectomy can be done. Please remember, we can go for yearly cholecystectomy in these patients who are negative predictive factors are absent. What is this? Is a protocol from Bailey and Love. So no negative predictive factors. What is this? Negative predictive factors are not there, and favorable organ system failure means favorable organ system failure is rapidly reversible after admission and before laparoscopic cholecystectomy. So the negative predictive factors include jaundice, neurological dysfunction, respiratory dysfunction. So don't forget the negative predictive factors are jaundice, more than 2 milligrams per deciliter, neurological dysfunction, and respiratory dysfunction. If these three are not there, or if they are present and they are reversible within 24 hours, we can go for yearly cholecystectomy. This is according to this table. You can see antibiotics and general care, no negative predictive factors and favorable organ system failure, and good performance score and advanced center, you can go for a yearly lab cholecystectomy. This is a very important point. You should not forget. A new update from 28th edition Bailey, because in old Bailey as well as in Subsistent, the answer for acute severe cholecystitis grade 3 was only percutaneous drainage. See, urgent gallbladder drainage was the only option. Now it is changed. In new Bailey, it is changed to yearly lab cholecystectomy can be done when the favorable organ system failure is present. Okay, that is one important point. Do not forget, this is a new update from Bailey and Love 28th edition. So this question came in the exam. I request you guys, please go through the images of various procedures like a T-tube cholangiogram. Should not forget the image of T-tube cholangiogram image. Should not forget the picture of intraop cholangiogram. You can just Google and find out all these images. Intraop cholangiogram, PTBD, percutaneous transhepatic cholangiogram. These three images, image-based questions may be asking first for the exam. So when this question came, most of the students wrote answer as percutaneous cholangiogram. No, this is a picture of intraoperative cholangiogram. Okay, it's a picture of intraoperative cholangiogram. This is a cholangioscope, which is, you can see very classically, they have cannulated near the cystic duct and pushing the contrast and seeing the like intraop cholangiogram is image here. So although debated, the routine use of intraop cholangiogram does not reduce the incidence of injury. So does not reduce the incidence of injury to the bile duct. Please remember, interesting point. Intraop cholangiograph will not help you to reduce the incidence of biliary injury, but it helps you to find it out early. That is a very important point. It will not help you to prevent the injury, but will help you to find out the injury early. So advocates for routine intraop cholangiogram note that the common duct injuries can be identified and managed immediately and cholangiograph is used routinely. That is advantage. So in early management is possible because of intraop cholangiography. So what are the indications of intraop cholangiography? Tokyo guidelines does not recommend routine intraop cholangiography. Pain at the time of operation, abnormal LFT, anomalous biliary anatomy, inability to perform post-operative ERCP, dilated biliary tree, and any suspicion of CBD stone. In these cases, we have to go for intraop cholangiography. So don't forget this point. So when will you go for intraop cholangiography? This table is a very important table from Subsistent. You can get this table. So don't forget this intraop cholangiography image-based question was asked in the exam. So these are the questions from gallbladder. You can see gallbladder chapter alone, we had around 5 questions. So 5 questions came from gallbladder chapter. Now let us discuss the questions from pancreas and spleen. So not a procedure for chronic pancreatitis. From these questions, you can understand nothing. No question is based on concepts like no questions based on like fact-based or one-liners, values. Nothing is. They'll ask only questions based on concepts which you'll be easily able to answer. So not a procedure in chronic pancreatitis. Dual procedure, phrase procedure, Burns procedure, Appleby, which is not a procedure in chronic pancreatitis. Can you tell me? Answer is Appleby. Appleby is a different procedure. I will explain later. So there are many procedures used for chronic pancreatitis. The commonly done procedure is we open the duct and we anastomose it like this. This is Partington-Rockel. This is Partington-Rockel, also called as modified Pusto, in which we did a lateral pancreatico-jejunostomy. So then what is original Pusto? Please understand what is original Pusto is. Original Pusto left open the duct fully like this, and he removed the spleen and he invaginated the bowel like this. Invaginated the bowel like this. This is original Pusto. Before this, there was another surgery called as child and dual. Child dual, that is, this opened the duct like this, and they removed the spleen and did a anastomose like this. They did anastomose to the distal pancreas like this. So they didn't invaginate. This is called as child dual procedure. So there are different procedures. Child dual only did a distal anastomose like this. Original pusto invaginated inside. Modified pusto didn't remove the spleen at all. So modified pusto, spleen is not removed. In these cases, spleen too are removed. This is very commonly done. Old procedures. Nobody is doing child dual or nobody is doing original pusto. All are doing only Partington-Rockale nowadays. So pancreatic duct dilatation is defined as a main duct more than 7 mm. When it is accompanied by intractable pain, this is treated by a side-to-side pancreatic jejunostomy known as modified pusto. Modified pusto, palliation of pain is 80%. Therefore, surgeons went on to the next procedure called as phrase head coring. So in which phrase head coring, we just, apart from this drainage, we also did a head coring of this pancreatic head. So when you do head coring along with the opening, that is called as phrase procedure. So phrase is also like a lateral pancreatic jejunostomy. We did a coring of the head. The main disadvantage is the removal of the pancreatic parenchyma, but that is not going to play a major role. Most of the 95% of the patients had satisfactory pain control in this. So pusto 80% pain control, phrase 95% pain control. So there are other two surgeries like duodenum preserving pancreatic head resection. In this operation, you can see there are two anastomosis done. Here one PJ, here one PJ. Bile duct comes, bile duct also is anastomoted. HJ is also done. So this is called as Beager. Beager has two anastomosis. In Burns modification of Beager, he just left the posterior capsule. He didn't disturb the posterior capsule, so he did only one anastomosis. Only resected head resection. Head resection and anastomosis also. That's very important point. You should not forget. What is done in Burns modification of. So modified pusto and Partington-Rockale are same. Modified pusto is nothing but the name of Partington-Rockale. Both are same. Original pusto is only they removed spleen and invaginated. Modified pusto and Partington-Rockale is what we are doing regularly in practice now. Okay, that both are same. So now what is this Appleby procedure? Appleby procedure is not a question for NEET SS, but it is a very common question for INI SS surgical gastro exam. Appleby procedure, original procedure was done for cancer stomach infiltrating into the celiac artery. So cancer stomach infiltrating into celiac artery, they resected the celiac artery and did a and they ensured. See, please remember, they ensured after resecting the celiac artery, they ensured common hepatic artery receives blood flow from blood via gastroduodenal artery. This is what they ensured when they are doing cancer stomach operation. So after cancer stomach operation, if you resect the celiac artery, the only important artery now is the common hepatic artery. Now the common hepatic artery will receive the blood supply in a retrograde direction from SMA to inferior pancreatic duodenal, superior pancreatic duodenal to the gastroduodenal will supply the hepatic arteries. That is what the plan. So when you resect the celiac artery, the same concept was modified into modified Appleby. Modified Appleby is done for distal pancreatic cancers. Distal pancreatic cancers infiltrating into, not for head of pancreas, infiltrating into celiac artery. See, original pusto of cancer stomach infiltrating into celiac artery is no more done. Original Appleby. Nobody is doing original Appleby nowadays. So still people started doing modified Appleby. Same concept was used. So in modified Appleby, stomach is not removed because it is not involved. Stomach is not involved. You only remove the distal pancreas. Stomach is not removed. Otherwise, everything else is same. In modified Appleby, stomach is not removed. We removed the celiac artery and we ensured the blood flow is retrograde from gastroduodenal artery. So this is the concept of modified Appleby. Please remember, this is an image-based question for INISS. Okay, this is Appleby procedure and modified Appleby procedure. 25 years male with the weight loss and fever for 4 weeks and associated abdominal pain for 8 weeks. The elevated WBC count, CT scan is shown below. So definitely there will be a question on CT scan images of pancreas, liver. So please go through all the CT scan images of pancreas and liver. This is a classical image of pancreatic necrosis. Is it a sterile necrosis or infective necrosis is the question now. So infective necrosis will have air in the necrosis. Air in the necrotic areas you have. Classically, you can see small air packets. This air packets is more in favorable of pancreatic infective necrosis. If you have a doubt, what will I do? If I have a doubt whether it is infective necrosis or a sterile necrosis, I should do a CT guided FNA and send it for culture. CT guided FNA should be taken and send it for culture. Even if culture is negative, we have found 40% of the cases still have positive for necrosis. So please read this paragraph from sub-assistant. CT is the most reliable technique and are typically seen as areas of low attenuation. Less than 50 ounce-per units is a necrotic area. Normal parenchyma has a density of 100 to 150 ounce-per. Up to 20% of the patients with the acute pancreatitis develops acute necrotic collection. Infected necrotic collection should be suspected in patients with a prolonged fever, WBC elevation, and clinical deterioration. It also should be suspected in patients who are developing sepsis, SIRS, or organ failure. Evidence of air is a confirmatory finding, but it is a rare finding. If infective necrosis is suspected, you should take an FNAC. And FNAC should be sent for culture. If although positive cultures are confirmatory, a review has demonstrated negative preoperative culture, 42% of them had persistent unwellness and will have an infected necrosis. Even if the aspirate is negative, 42% may be having infective necrosis. Please remember this pancreatic necrosis concept. So I hope all of you know what is Panther trial. Panther trial related to pancreatic necrosis is a step-up approach. So please read about Panther trial from Bailey and Lowe. In the step-up approach, the last step is Beger's lavage procedure. Beger's lavage procedure is a last step. Please go through this in Bailey and Lowe. 28th edition has given an image of this. Beger's lavage procedure is mentioned in Bailey and Lowe 28th edition. So Panther trial. Pancreatic necrosis step-up approach trial. Pancreatic pseudocyst, decision on cystogastrostomy or cystoduodenostomy depends on dash. So this is a classical picture showing you the pancreas. Now, the location of the cyst is very important. When there is a pancreatic pseudocyst, depends upon the location. If it is in the body and tail, it can be easily found to compress on the stomach. So you can easily do a thing. And if it is in the more close to the duodenum, you will go into a cystoduodenostomy. It is here, you will go for a cystogastrostomy. Sometimes it is located inferiorly somewhere. We will go for an isolated limb like cystojejunostomy. So it all depends upon the location of the cyst. So don't forget, it is a CT scan location of the cyst decides the cystogastrostomy. So cystogastrostomy decided by location of the cyst. Pancreatic pseudocyst is decided by the location of the cyst, and definitive location treatment depends on location of the cyst. So what is the DEGDO classification? DEGDO classification. It is of type 1 pseudocyst following acute pancreatitis. Type 2 pseudocyst following acute on chronic pancreatitis. Type 3 is follows chronic pancreatitis. It follows chronic pancreatitis, and this is having more than 50% as communication. More than 50% of chronic pancreatitis will have communication. So this is a DEGDO classification. Don't forget, DEGDO classification is type 1, type 2, type 3. So there are 3 types of DEGDO classification. Definitely see the line from sub-assistant. I'm telling you, you will get line questions directly from the sub-assistant. So I would have made the question simple, but the exam question will be like a clinical bigger question, and you will be getting confused reading the question paper. So please remember, definitive treatment depends on location of the cyst. Pancreatic pseudocyst closely attached to the stomach will be treated by cystogastrostomy. Located in head of pancreas that are in close contact with the duodenum are treated by cystoduodenostomy. Some pseudocysts are not in contact with the stomach or duodenum. Go for cystojejunostomy. Surgical cyst enterostomy is successful in achieving immediate cyst drainage in more than 80% of the cases. So don't forget this point. So here is a question from SOFA score of pancreatitis. I don't know whether it is a pancreas related question or a general surgery related question, but this question I have took the answer from Swartz. Can you tell me which is not included in SOFA score? So please remember, SOFA score is a score sequential organ failure assessment score, which is related to sepsis or septic shock, which involves failure of any organs like lungs, heart, CNS, brain, CNS like brain or liver or blood. So 5 organs, remember, any failure of any one of these organs is called as SOFA score. So except total leukocyte count is not included in this score. So total leukocyte count will come in SIRS. SIRS is including WBC count, temperature, okay, heart rate, and respiratory rate. This is SIRS, WBC count, temperature, heart rate, respiratory rate. This is not Q SOFA. Q SOFA, all of you know very well. It is respiratory rate, confused status, and RCB, B for blood pressure. So this is Q SOFA. Here, this is the question of SOFA. SOFA score is available for pancreatitis. It is there a table from SWATs. So I always say SWATs is not so important to read, but definitely some 3 or 4 questions will come from SWATs, which are not going to decide the rank. If you are going to be very strong in all the Sabiston-based questions, you can answer most of the questions. Sequential organ failure score in acute pancreatitis is a table is there in SWATs. Respiration, coagulation based on platelet count, bilirubin, hypotension, Glasgow Coma Scale, and kidney. So these are the factors included. So in what are these included? Creatinine, Glasgow Coma Scale, hypotension, bilirubin, platelets, and PaO2, FiO2. This is the 6 factors included in SOFA score from pancreatitis score. So please don't forget this table. If you have time, take this table from SWATs and you can go through this table. But I don't think they will ask you the values and all, but they just asked you what are included in the SOFA score. Okay. This is a question from general surgery, maybe from pancreas also, we don't know. So endoscopic picture of ampulla is shown below. So classical picture, all of you would have answered it immediately. Fish mouth ampulla. This is called as fish mouth ampulla associated with dilated pancreatic duct and mucin secreting. This is a classical triad called as, what is the name of this triad? Bulging ampulla, dilated duct, mucin secreting papilla is called as Okashi triad. Okashi triad is a feature of IPMN, intraductal papillary mucinous neoplasm, has this triad. It is from SWATs as well as from all surgical gastro books as this name. So bulging ampulla, dilated pancreatic duct, and mucin secreting neoplasm. See, IPMN is usually arising from the duct at the part of head like this. So IPMN arises from the head like this. Since IPMN is a mucin producing tumor, it secretes mucin into the duct like this. Therefore, the duct is fully dilated. It is fully dilated. So IPMN will have dilated ducts on either side, both sides. And you can see mucin secreting into the ampulla like a fish mouth ampulla appearance. And very important point, when we analyze the fluid on EUS analysis shows CEA increased in the fluid, amylase increased in the fluid, and mucin is increased in the fluid. All are increased in this fluid. So IPMN is a very favorite topic. So there will be no calcification. Calcifications in parenchyma is absent. So please don't forget. So imaging demonstrates diffuse dilatation of the pancreatic duct, and the pancreatic parenchyma is atrophic due to chronic duct obstruction. So it may look like chronic pancreatitis, but don't forget it is not chronic pancreatitis because there is no calcification or a beaded appearance is not present here. A DRCP mucin can be seen extruding, giving the fish eye lesion, and initial reports suggested male predominance, but now it is equal distribution. The patients are usually in their old age with abdominal pain, and recurrent pancreatitis may be present in this Okashi triad. Okay, so there are 5 questions from pancreas. And now splenic trauma, it may be a trauma or a splenic question based on the investigation, which is an indicative of active bleeding. So free fluid in the peritoneum, areas of hyperattenuation within the spleen, subcapsular hematoma, perisplenic hematoma. So there's a grading of spleen. I hope you know AAST grading, you should go through AAST grading. A new update, they have added grade 4 and grade 5, 2 points are added. Grade 4, there is a vascular injury with intraparenchymal bleed. 5 is vascular injury with a peritoneal bleed. The peritoneal cavity is full of blood. So that is grade 5. This is a new update from, apart from the routine things, I hope you know what is grade 1, grade 2, grade 3. So less than 10% hematoma, 10 to 50% hematoma, more than 50% subcapsular hematoma, laceration less than 1 centimeter, 1 to 3 centimeter laceration, more than 3 centimeter laceration. These are common points. So, but extra point, grade 4 is now having a vascular injury with an intraparenchymal bleed. Grade 5 is shattered spleen or a bleeding into the peritoneal cavity. So now the question is, they are asking what is indicative of active bleed. If it is inside the parenchyma, you get a appearance like this. If there is a bleeding actively going on into this, you can see like an aneurysm like appearance into the spleen. So if it is extravasating, you see the contrast coming out extravasation. So in all patients, abdominal CT with IV contrast is most valuable study. Splenic injury appear as disruptions in the normal parenchyma. Active bleeding can be identified by visualizing extravasation of contrast material. At times of extravasation, free into the peritoneal space or within the intraparenchyma as pseudoaneurysm. This is grade 4 and peritoneal space is grade 5. So a splenic injury with active extravasation into a pseudoaneurysm is demonstrated in the image below. So this type of cases, we have to immediately go for splenectomy. If patient is unfit, you can also go for angioembolization. So splenic artery aneurysm is a failure of non-operative management. We have to intervene such type of splenic artery aneurysm. It is a tumor blush-like appearance on CT contrast. So don't forget, splenic trauma is a favorite topic of NEET SS. Definitely you'll get a question from splenic trauma. Post-splenectomy, accidental removal of the Rayleigh tube by the patient himself on post-operative day 0. With the post-op vomiting with the fullness in the upper abdomen. What is the diagnosis? So it's one of the yearly complications, very common, seen after ligating the short gastric vessels. Since we are short gastric vessels which are going like this are all cut. When we are doing the splenectomy, we are cutting the short gastric vessels. The stomach can go for a type of ileus that is called as acute gastric distension. Or it can even go for ischemic necrosis, gastric distension, ischemic changes, ischemic necrosis, or it can even go for leak. All these are possible from the greater curvature side. So please remember, so major, these are all acute complications in the post-op, immediate post-op period, but the most common immediate complication is left lung atelectasis. So most interesting question for all your exams is on OPSI. You will always get questions from OPSI. So short-term complications are bleeding, pneumonia, left lung atelectasis, left low pleural effusion, pancreatic leak, gastric perforation, thrombosis, post-splenectomy thrombosis because of increasing platelet count, especially for vascular disorders. When you're going for a splenectomy, they have a increasing vascular counts, like platelet count increases. And if it goes more than 10 lakhs, if the count goes more than 10 lakhs, immediately you should start antiplatelet drugs. If you are not going to watch very closely, they can even go for portal vein thrombosis. Be careful. It is very common complication, especially for cases we are operating with a huge spleen. So late complications are DVT, pulmonary embolism, and OPSI. OPSI is common between 2 to 5 years. So it's a most common fatal complication. It usually occurred more than 2 years after surgery, and 42% occurred more than 5 years after surgery also. So it is not common in the first 2 years. So mortality may be very high, and it is very common in vascular pathologies like thalassemia, sickle cell anemia. They develop these points, okay? So in case of splenic artery aneurysm, as a sequelae of CCP treatment for symptomatic is embolization or open ligation. See, when your CCP patients coming, if you are going to plan for a surgery for a chronic calcific pancreatitis, at that time we will do splenectomy also. For a splenic artery aneurysm, when we are planning a CCP treatment, we will do splenectomy also. If I'm not going to plan surgery for CCP and there is a splenic artery aneurysm, in such cases, we only go for embolization. No need to go for surgery. Okay, surgery is done only for trauma patients, not for CCP with the pseudoaneurysms. Okay. Splenic artery aneurysm is a separate topic. You can go through. What are the indications of surgery in a splenic artery aneurysm? Young females, more than 2 centimeter, pregnancy, all those things are there. You can see there is a separate discussion on splenic artery aneurysms from substance. Please go through that. Okay. So therefore, these are the questions from pancreas and spleen. Now we go to the liver chapter. So while handling the liver trauma, post-hepatic IVC bleeding management. So you can see more of trauma questions. So though I have discussing in abdominal trauma, these are all trauma questions which can be considered as a trauma topics also. So please go through trauma. Strong concepts which should be there for you from trauma. So go through trauma topics, especially our DocTutorials and materials from DocTutorials and basic points from substance you should not forget. So while handling a liver trauma, post-hepatic IVC, that's a retrohepatic IVC. So then there is a retrohepatic IVC injury, which is bleeding like this. How can I manage this bleeding? So many methods are explained there. Very clearly, Sabiston says the best method, in spite of various heroic measures, is go for tamponade. Just give tamponade. There are so many methods explained, but none of them will be best. So the best method is tamponade. See the lines. Liver injuries in the vicinity of retrohepatic vena cava that are not actively bleeding should be packed and not explored. Which is retrohepatic vena cava that are not actively bleeding should be packed and not explored. There are many heroic techniques. See the line. There are many heroic techniques described in the literature that outline the repair of retrohepatic vena cava, but the approach with the greatest likelihood of success is preserving the natural tamponade of this low pressure region when feasible. So an atriocaval shunt, the people tried a shunt like this from here to atrium. Shunt has been tried. Atriocaval shunt will be done, and you clamp this retrohepatic IVC here along with the Pringles plus clamping of the IVC, and we will do a atriocaval shunt. And we have a time to repair this injury. All these are discussed. Isolation of liver with the atriocaval shunt with addition of Pringle maneuver theoretically allows repair of vena cava or hepatic veins with less ongoing blood loss. It's a theoretical point. And the best method is very clear. It is tamponade effect. Okay. So elderly male with a mass in the liver segment 4. CT showing, actually this is not the exact segment was given in the image. It was an image-based question. I didn't get that image, typical image. So just remember, elderly male with a mass in the segment 4. CT scan showing arterial phase enhancement and portal venous phase washout. It is a very basic question. Nothing was given. No theory was given. Just gave a patient the mass and they gave the pictures of these two pictures. For example, this picture was given that this is one phase called as arterial phase. Don't forget. Arterial phase, this is a picture of arterial phase done at 18 to 36 seconds. You can see the tumor is supplied by the artery, so it immediately enhances hyperdense, whereas the liver is hypodense. Then coming to portal venous phase, you can see that tumor is not seen, but the liver is enhancing. So this is a typical rapid washout. Rapid enhancement and rapid washout is a classical feature of HCC. So that is hepatic adenoma. Answer is hepatic adenoma. Sorry, hepatoma, not hepatic adenoma, hepatoma. So hepatoma is other name of HCC. Okay, just remember it. Hepatocellular cancer. So liver cell adenoma has a peripheral enhancement with the centripetal progression. Liver cell adenoma seems to be heterogeneous on CT scan due to intratumoral hemorrhage and necrosis and fat content. It is heterogeneous. Okay, liver cell adenoma is heterogeneous, whereas rapid enhancement and rapid washout is feature of hepatoma, HCC. Okay. Patient presenting with jaundice, right upper quadrant pain, and upper GI hemorrhage. What is the diagnosis? So this is a classical triad. What triad? Sandblom's triad. What is Sandblom's triad? See, this is a classical triad of Sandblom. A patient is having bile duct like this. Into the bile duct, some blood vessel is bleeding into the bile duct and blood is coming into the bile duct and some clots are obstructing the bile duct. Therefore, the patient is developing jaundice. First point, jaundice. And since clot is obstructing, they also have pain. And since blood is coming in the stools, they also have melena. So this is called as Sandblom's triad, also called as Quincke's triad. Very good, Quincke's triad. So it is called as Quincke's triad or Sandblom's triad. It is called as hemobilia. Please don't forget, it is called as hemobilia. Hemobilia is not a disease, it is a symptom. Please don't forget, hemobilia is a symptom, not a disease. Symptom of many pathologies. Can you give me a few pathology? Means the most common pathology is iatrogenic. Following some surgery or some, for example, even after a percutaneous biliary stenting, you can get this. Iatrogenic, following a liver resection surgeries or following a tumor infiltrating into the bile duct. So iatrogenic is most common, or it can be due to tumor. Many causes are there. Hemobilia is a very common pathology. So don't forget, the blood enters into the bile duct. That is called as hemobilia. Blood into the bile duct. There is another similar condition called as bilhemia. This is very rare condition in which the bile is now entering into the blood vessel. Why is it happening? Usually it will not happen. When the bile duct pressure is high, when the bile duct is obstructed or there is a high pressure in the bile duct, it enters into the blood vessel, especially it enters into the veins. So when a bile enters into the blood vessel, what will be the clinical feature? The patient will have bile entering into the blood. He have jaundice. They also have jaundice. But the jaundice is very interesting here. It will be having elevated bilirubin. It will be having elevated bilirubin, especially direct bilirubin. But there is no elevation of, yes, what are the no elevation of? Alkaline phosphatase or liver enzymes. SGOT, SGPT and all will not be elevated in bilehemia. Don't forget, bilehemia is also due to same pathology only. So there is an obstruction in the distal bile duct and you have done some procedure and now obstruction not got relieved. So therefore bile enters into the bloodstream. So treatment of choice for bilehemia is very easy. Just do a ERCP plus sphincterotomy. The pressure decreases and the bile will not flow into the bloodstream. Very good. So that's a bilehemia. Alkaline phosphatase will be normal. Only bilirubin will be elevated in bilehemia. Don't forget this point. That is a classical point of bilehemia. So bilehemia treatment of choices, ERCP and sphincterotomy. For hemobilia, treatment of choices, call the radiologist for an angioembolization. So both would have been happened due to iatrogenic. So don't forget about hemobilia and bilehemia. So the symptom shown here is a Quincke's triad or Sandblom's triad. It is from Sebastian. So upper GI bleed, colicky pain, and jaundice. It is a typical Quincke's or Sandblom's triad. So definitely you will get a question from shunt. I don't think this is a class to discuss about detailed shunt discussion. So you all have the app. Go through the app, DocTutorials app, and see the shunt operation discussion. So which is selective shunt shown in the picture. So porta-caval side-to-side shunt is a non-selective. End-to-side is also called as X fistula, is also non-selective. So this is a proximal splenorenal shunt. Proximal splenorenal shunt called as a Linton shunt. So in which splenectomy is done? So in which splenectomy will be done? There is another shunt, distal splenorenal shunt called as Warren shunt. So this is the selective shunt. All others are non-selective shunts. So is there any other selective shunt? Means yes, Inakuchi shunt. It's a selective shunt. Inakuchi is a left gastric vein to IVC shunt. That is also called as selective shunt. It is also a selective shunt. What is Sarfe shunt? It is an 8 millimeter interposition shunt. It is called as Sarfe shunt or partial shunt. Sarfe or partial shunt between IVC and portal vein. Interposition shunt, it's a partial shunt between IVC and portal vein. So please don't forget the answer for this question is Warren shunt. Schematic representation is Warren shunt. So very bad time, only 4 questions came from the liver, and that too only 3 from proper liver and 1 was from trauma in the exam. So now coming to the, if you count together Hepato-Biliary pancreatic system, so around 14-15 questions came from Hepato-Biliary and spleen. So around 150 questions, 15 questions are from Hepato-Biliary and pancreas. So 10% of the questions will be from Hepato-Biliary, and around 10 to 20% questions will be from gastro also. So very important section, GAT and HBP. Since most of you will be preparing for gastro, you will be strong in these concepts. So now going to transplant, see, when I was taking transplant questions for the past 3-4 years, when we go through the 3-4 year question, only 1 or 2 questions have come from transplant, and they are also very basic questions, which are all taken from Bailey and Love, not even from Sabiston. Most of the transplant questions were taken only from Bailey and Love, not even from Sabiston. That is why we stopped discussing about transplant questions in the face-to-face classes. We have discussed in detail in the app, but not doing in the face-to-face classes. So HLA, most important is DR. Please don't forget. See, there is a HLA A, B, DR. Only these 3 matches we are seeing now. So HLA, B, A, B, DR of the patient. HLA, A, B, DR of the donor. In this, most important is DR. If any one, no mismatch between any of this means we call them as 0-0-0 mismatch. 0-0 mismatch is an ideal organ. The best matched grafts are described as 0-0-0 mismatch. This is from Bailey and Love, not from any other book. So 0-0-0 mismatch is perfect graft. Perfect graft is 0-0-0 mismatch. So no mismatches. If there is any one or any 2, accordingly we have to tell them as 2-2-2 mismatch. So every individual has 2 copies of HLA gene. So for each locus A, B, or DR, it is possible to have 0, 1, or 2 mismatched genes. So accordingly, they mention as if there are no mismatches, 0-0-0. If there are 2 mismatches, 2-2-2. The effects of different HLA antigens are not uniform. DLA mismatches have a more powerful effect than B or A mismatches. So most important in this is HLA-DR mismatch. HLA-DR mismatch, if you do for a kidney transplant, definitely there will be rejection. Please don't forget this. So there are 2 questions in the same exam on relative contraindication of liver transplant. So the liver transplant contraindication, like that, there are 2 questions seen. So in the relative contraindication for liver transplant, answer is any tumor in the body. So any malignancy is a contraindication. TB, HIV, obesity are all now not a contraindication. So another question was also there, liver transplant contraindication. HIV was once upon a time a relative contraindication. So you have to go through this list of contraindications in Sabiston. But this question actually was not a proper recall, but every year they're asking questions from liver transplant contraindications. So what is the latest update in Sabiston? So advanced cardiac disease, severe valvular heart disease, pulmonary hypertension, portopulmonary hypertension, uncorrectable to less than 50. Hepatopulmonary syndrome where PaO2 not correctable on 100% oxygen. So these are called as, so malignancy within 5 years is a contraindication, except malignancy within 5 years is a contraindication. And can patient who died of skin cancer, brain cancer, uterine cancer is not a contraindication. Skin cancer, except melanoma, brain cancer, uterine cancer, these are not contraindications. So just this is a point given in Sabiston. You go through this. Irreversible neurological impairment, uncontrolled sepsis, patient dying of any extrahepatic cancer. That is why I told you AML might be a contraindication. So following are no more contraindications. HIV, alcohol abuse, anatomical reasons are removed in new books. Okay. So just remember this points from Sabiston, but please go through the contraindications of transplant from Bailey and Love. That is more than enough. These are the questions from HBP and transplant. So there are various faculties coming for a discussion of NEET 2023 paper. So try to attend the session. Even if you are not able to attend, the sessions will be recorded and will be available in the same YouTube channel. So we'll be discussing NEET SS 2023 first. And then after finishing this, we'll do the NEET SS 2022 discussion. Okay. So thank you all. Any doubts? You can post in our WhatsApp group. I hope all of you are in the WhatsApp group. You can post that. Thank you so much.
Thank you, sir.
Thank you, sir. Thank you.